Dear colleagues, first of all, hello around the world. It's a great pleasure to be part of the Geistlich webinar tour this year, and I hope all of you good, all of you are safe, and I'm very happy to share some ideas, to share some knowledge with you through this channel, through this internet channel, and I think it's a nice opportunity for us to connect throughout the whole world. Well, my topic is soft tissue management around dental implants, and in particular how soft tissue management and also maybe use of soft tissue matrices can help us to avoid complications around dental implants like peri-implantitis or soft tissue recessions. Well, of course, the first question would be, is the thickness the key, or what aspect of soft tissue is the key for long-term stability and to avoid complication around dental implants? Well, as a periodontist, I would like to go back to teeth and ask myself, what do we know about soft tissue around teeth? And I think the evidence is quite clear around teeth and around dehiscence defects. We know that the soft tissue thickness is the major key for long-term stability. So let's quickly run through a case. This is a lower canine with a recession, a gingival recession, and you clearly see that there's a lack of soft tissue in the root of this canine. So what we do is we correct soft tissue with soft tissue, so we don't take care about bone, so we correct everything with plastic periodontal surgery and reconstruct everything with soft tissue. So here's the final restoration, or the final result after the surgery. You see it's a double pedicle flap, which is combined with a connective tissue graft underneath it. And you see the major aspect of it is the over contouring of the soft tissue in a more coronal position and the stability, the stabilization of the soft tissue with sutures. Now, if you look into this case 3 years down the road, you see this clinical situation. And you see there's no inflammation, there seems to be stability over time. This is 3 years post-op and probably also over a longer time period. And we have the longer documentation in this case, so we can look into the 5 years post-op result. You see also literally no change, still an adequate soft tissue thickness, the complete coverage of the recession is still there. And if we look into this case after 9 years, we see that the clinical situation is more or less the same than it was some years ago. Now, coming back to the question we had in the beginning, let's start to rethink about the evidence or the idea of soft tissue in the field of implants. Well, we see that going back to teeth, soft tissue thickness and attached mucosa seems to be very important for long-term stability. So if we start the topic and ask ourselves, well, what do we know from the field of plastic periodontal surgery, where we actually have all the evidence from and also all the experience from? Well, then it's quite clear. We know that it's not underlying bone. We know that it is an adequate amount of soft tissue thickness, which is determining the long-term stability after coverage of recession type defects. So more or less, to answer the question, what are we doing in the field of plastic periodontal surgery? What are we doing in the field of recession coverage with our soft tissue? Well, we thicken the soft tissue biotype, and that seems to be stable over time. Now, let's transfer this a little bit to the peri-implant soft tissue. Can we transfer the same thing? Can we say then if we have thickened the periodontal biotype, then this situation seems to be stable over time? And maybe even more, is it soft tissue thickness, meaning a horizontal soft tissue thickness, which is on the buccal side or on the palatal or on the lingual side of the implant? Or is it maybe soft tissue height, meaning the peri-implant soft tissue over the implant abutment junction, which may also play a role around dental implants because we suddenly have a micro gap in this construction. Well, I would like to show you a case which I think clearly shows the differences between teeth and implant, and that it is probably, well, a little more complex around dental implants, because we just saw around teeth it is thickness and attached mucosa. The underlying bone doesn't seem to play that major role after recession coverage. Well, around dental implants, it may be more difficult. So let's look at this clinical situation. And well, from the outset, it probably doesn't look much worse than the situation we just saw around this canine. Okay, we accept that we have maybe a little more multiple recessions, but we also have only one major recession around tooth 1-1, so the right central incisor, and we have some shallow recessions around the lateral incisors. Of course, what we're already expecting, there's no bone underneath it, and we probably see that the implants are malpositioned, they're more positioned to the buccal side. So the question is, can we correct this also with the same approach we learned around teeth? So what did we learn around teeth? Well, we learned we do not need to take care about bone. The only thing we need to do, we need to increase soft tissue thickness. We need to cover our recession with attached mucosa, and we need to stabilize the flap in this coronal position. Well, let's look at this surgery, and I brought this surgery for you because at this time, this is a little longer ago. Well, of course, you always have a very, very tough decision as a clinician. Do you want to take out these implants? Do you want to start all over again? Or maybe is there a chance to redo the surgery, to reconstruct everything with the techniques we learned from the field of periodontal plastic surgery? So what I did a tunneling approach in this context. As you already see it here, quite difficult because the tissues, they stay a little inflamed, although this is pre-treated. But of course, as you know, around dental implants, it's always very difficult to get the tissue without inflammation. Now, connective tissue grafting from the pellet, as you see it here. Then I used a power air abrasive in order to decontaminate the implant surface. And then I used a sling suture to more or less incorporate the connective tissue graft into the tunnel which I created. If you look at the situation directly post-operative, pretty good result. And I pretty much did the same thing what I would have done around teeth. So I thickened the periodontal biotype, I stabilized the flap in a more coronal position, and I used keratinized tissue in order to overcome this problem in this situation. Well, this is the clinical situation directly post-operative, and this is the situation 10 days after surgery. And you clearly see, well, the result is not bad for 10 days after surgery. And most of you are experienced with recession coverage around teeth. You all know if you have achieved this result after 10 days, you probably are sure that this is going to be a good result. However, not around implants. This is 3 months post, and this is 6 months post. So let's be clear from the beginning. Soft tissue management around dental implants is different to soft tissue management around teeth. Why? Well, probably we have more determining factors. And one determining factor is, of course, the lack of attachment. The second determining factor is, of course, that it is very difficult to stabilize this flap here in a coronal position on this very, very smooth implant surface. And the third aspect is, of course, the positioning of the implant, which you probably cannot change around teeth. You can change this a little bit, maybe you grind away a little bit of the tooth structure. Around dental implants, you cannot change that. So let's look at from the outset. If we want to talk about soft tissue management, what aspects are important? This is only one mosaic stone of many, many mosaics in this field? Well, of course, the position of the implant. Look at the clinical situation on the left side. Well, the implant is positioned too far to the buccal, and there will not be any bone on the buccal side. And of course, you cannot change the angulation. So soft tissue management is very difficult in this case. The amount of bone is very important. Danny Boozer and his study group has clearly shown us that an adequate amount of bone on the buccal side of an implant is necessary to support the soft tissue. Prosthetics may play a role. We know how smooth an abutment surface has to be. A polished zirconia is probably the best you can do for your soft tissue, for your subgingival soft tissues. And also this is very important in order to support the soft tissue. The implant system per se, of course, I mean, the more you have a system which is a two-piece implant system with a conical connection, the more you place the implant deep. The more you have a one-piece implant system, maybe with a flat-to-flat connection, the more you place it more to the coronal. So also this plays a role on the amount of soft tissue which you may need around your dental implants. And of course, plaque control plays a role in the maintenance of soft tissue. And of course, at the end of the day, the soft tissue height and thickness plays a very important role in this aspect. Well, the first point I would like to make is the bone. We just saw that around teeth, it's not really important how much bone is on the buccal side when we correct our recession. We have seen that we are able to correct gingival recession without taking care too much of the bone. Around dental implants, I think it's different. I think Chapi from the Burn Group has clearly shown us that a certain amount of bone on the buccal side supports the soft tissue. This seems to be different to teeth, probably because of the attachment which we have around teeth. So here in the study, in the 10-year study, very nice, they document that the peak of the facial bone thickness was significantly correlated with the soft tissue thickness, which is very important, that bone seems to be correlated to soft tissue thickness around dental implants. So let's put it in a nutshell. No bone, no soft tissue. And I think this is important before we talk about soft tissue correction or soft tissue measures to improve the prevention around dental implants. If you don't have bone on the buccal side, I think it's very, very difficult to do soft tissue management. So make sure you have an adequate amount of bone on your implant fixture, depending on the implant system again. But if you don't have any bone which is supporting the soft tissue, it will be very difficult to do adequate soft tissue management. Well, the next question is, what kind of soft tissue is important around dental implants? Is it the soft tissue thickness in a horizontal dimension, as you see it on the left upper picture? Is it maybe the soft tissue height in the coronal part of the implant fixture? So more or less how much soft tissue is over the implant abutment junction? Or is it more the quality of the tissue? Is it the attached mucosa? Is it attached and keratinized? What kind of tissue is important, or what kind of soft tissue is important? Well, to have a long-term maintenance of our dental implants. Well, more or less over the last years, soft tissue height has gained interest, because we have seen that the quality of tissue, so keratinized attached mucosa, seems to be important when it comes to the prevention of inflammation, when it comes to the prevention of recession. However, as a foundation of bone, we never saw a direct correlation. Now, then came the first studies which looked into soft tissue height over the implant fixture. And suddenly most of the studies saw a correlation between an adequate soft tissue thickness and the preservation of bone. So look at these studies here, Suarez, Lopez, Delamo. Implants placed with initially thicker peri-implant soft tissue have less radiographic marginal bone loss in short term. Interesting. So the height of the soft tissue supports the underlying bone. There are studies which are a little bit critical here from Akalchi, where there is not enough evidence yet. But of course, if you look into Diaz-Sanchez's work, there's a moderate certainty of the evidence for a large effect of marginal bone loss prevention in favor of a thick soft tissue attachment environment. So the thicker it is, the better it seems to be for the underlying bone. And of course, Dani Thomas' work for the Osteology Consensus Conference is clear that if you use autografts to improve soft tissue height, it seems to support the marginal bone levels. So, of course, and this should be the focus of this talk, is soft tissue height. An adequate amount of soft tissue height over your implant fixture seems to be important. So we know that a certain amount, Linkevicius has defined the 2 millimeters. Today we even think it's probably 3 millimeters, maybe 4 millimeters of soft tissue height over your two-piece implant seems to prevent marginal bone loss. Now, the question is for me, how do we gain this? How do we get 2, 3, 4 millimeter of soft tissue height over your implant fixture? Sometimes it's easy. For example, in the posterior maxilla, we sometimes have a lot of soft tissue. We sometimes even have to cut the soft tissue because it's maybe even too thick. But sometimes lower mandible, for example, it's quite difficult. It's maybe just a millimeter of soft tissue height, and probably to prevent marginal bone loss, you should augment. And now the question is, are we using autografts? Are we using xenografts? Or what kind of materials do we use? I have brought to you 4 examples or 4 clinical scenarios how we work with the soft tissue height, or how we attain soft tissue height in different indications. Well, the first approach is, of course, if you have everything, if everything is perfect, if you have a thick soft tissue, if you have an intact bone, then the best way to get soft tissue height over your implant fixture is to support everything. And to support it is, of course, use a bovine bone mineral and a provisional to support the soft tissue. So let's look in a clinical example into this situation where everything is perfect. So I have a situation where I want to place an immediate implant. Busa has shown that is possible if we have an intact buccal wall, if we have a thick parental biotype, if we're able to place the implant in a palatal position, if we're able to place it flapless, well, then we have everything. So then, of course, from a preventive aspect, the best way is not soft tissue augmentation. The best way is soft tissue stabilization. And what we know is grafting the gap with BioOs seems to support the soft tissue, and provisional at the same time of the implant placement seems to support the soft tissues also. So if you combine these 2 approaches, you have an adequate amount of soft tissue height in this clinical situation. So for me, the 2 most important examples is the support of the buccal bone plate. Remember, no soft tissue or no bone, no soft tissue. And if you have BioOs inside the socket, we have seen that, and we have done studies to that. If we have a support of the buccal bone plate, we also support the soft tissues in a more coronal position. The second aspect has been shown by many more scientific groups, is that we support the soft tissue with an immediate provisional. As you see it here, we have BioOs underneath it, which is supporting the bone, and then we have a soft tissue which is supporting the soft tissue height in this context. So let's look at the clinical scenario. This is a canine which had a resorption and has a through and through defect, and we decided to take out this tooth, and we thought of what is the right approach. And of course, from a soft tissue perspective, what is the right approach? Well, the right approach is to use an immediate implant to support the buccal bone with BioOs and to support the soft tissues immediately with a provisional in order not to get a collapse of the soft tissue, and by this attain an adequate amount of soft tissue height. Here's the clinical situation. You see everything is perfect besides that deep resorption on the palatal aspect. I have an intact buccal bone plate. I have adequate amount of soft tissue in thickness, an adequate amount of soft tissue height. So I can go for an immediate implant placement. And here's the surgery. So what we did is we took out the tooth. As you see it here, it's a pity to take out this perfect tooth, but because of the deep resorption on the palatal side, we agreed to remove the tooth. So we removed the tooth without more or less having clinching into the papillas and making a trauma in the papillas. Then we evaluated the buccal bone plate. We had an intact buccal bone plate. We had a thin buccal bone plate, but of course we were thinking of grafting this gap between the implant and the buccal bone plate. Then we did the pre-drilling. In this case, as you see it here, in a palatal position, like Busa has shown us, in a palatal position, a flapless implant placement, and then we place the bone level implant into the housing, as you see it here, in a palatal position. Make sure it's not going to the buccal, and as you see it here, implant is placed in the right prosthetic position. And then what we did is, well, we stabilized everything. So we stabilized the buccal bone with a bioos and used the tooth immediately as a provisional in order to support the soft tissue. Here you see bioos used in order to have the bone, which is stabilizing the soft tissue in this context. And then we used a provisional cylinder. We used the tooth, as you see it here, and we used the tooth as a provisional in this case in order to more or less give back the emergence profile immediately. So the tooth is inserted, as you see it here, and this is the concept, and this has been shown in a lot of studies. Is this immediate concept that it seems to work quite well if the prerequisites are there, and the prerequisites is an adequate amount of soft tissue thickness and height and an intact buccal bone plate. Now, let's look at the situation 5 months down the road. You see a nice clinical situation. The papillas are more or less completely preserved. And then, of course, it's quite easy to change this to the final restoration. And here, I think this is important for me. Coming back to the topic of my talk is adequate amount of soft tissue height. In this case, you probably cannot expect that there will be bone loss because you have an adequate amount of soft tissue height and also soft tissue thickness. And this is not at least because of the bovine bone mineral, which is in the apical part and supporting the soft tissue height. And final reconstruction inserted here with a screw retained final reconstruction. And here you see nice radiographic situation. You see no bone loss in this context, so the bone is more or less at the implant abutment junction, and this is probably also because of a simultaneous approach, but not at least because of an adequate soft tissue height and thickness. So the first aspect in preventing complications around dental implants and with respect to soft tissue is to support the soft tissue thickness or soft tissue height when it's already there. And this is a situation, of course, where you're using immediate implants, where you're using bioos to graft the gap, and you're using a provisional in order to support the soft tissue height. So what are we doing if we have a situation where we cannot go for immediate implant placement, but we at the same time want to increase soft tissue thickness and soft tissue height, of course, for our aesthetics, but also for our long-term prevention of complications, of our long-term prevention of marginal bone loss? Well, the data are quite clear. We see that the situation around bridge preservation, this is from the EFP and Osteology Consensus Conference, where I had the honor of being part of that group, what we saw is ridge preservation is quite effective when it comes to horizontal and vertical tissue alterations. And interesting enough, the best effect is by the use of a xenogenous or an allogenic material in combination with an autogenous or exogenous barrier material. So this means a combination of a bone filler and a barrier on top of it, which could be a barrier membrane, but it could also be an autogenous soft tissue. And of course, if the situation is thin from the outset, an autogenous soft tissue may of course be the right choice in this context. So what we have learned over the time is that these kind of saddle-shaped connective tissue grafts work quite well for us. So what we're doing is we're grafting the extraction socket with a combination of BioOs or BioOs collagen and Fibro-Gide, and then we're using a connective tissue graft to more or less slide that into the palatal envelope, into the buccal envelope, and more or less to do like a saddle over the extraction socket. So here's an example, a lateral incisor, and you see the clinical situation is not perfect. I have a thin soft tissue on the buccal side. I really don't want to place my implant immediately. Why? Because I have a thin soft tissue, and I'm a little bit afraid that I will not end up with a good result with an immediate restoration. So what we do is we do ridge and socket preservation. At the same time, we build up soft tissue in order to get an adequate amount of soft tissue height. So here's the surgery clinical situation of this lateral incisor. Very, very carefully extracting this lateral incisors, as you see it here. It had an endodontic lesion, as you see it here. And what we did is we took away the granulation tissue. We had a dehiscence in this case. So that what we did is we tunneled the buccal envelope. First of all, we curetted everything. Here you see the through and through defect. And in this case, I think autogenous soft tissue is the gold standard, because in this case, we need to prevent the shrinkage, but at the same time, we need to think of an adequate soft tissue thickness and height for the long-term maintenance of this implant, and also for the long-term maintenance of aesthetics in this case. So what I did, I used the connective tissue graft from the Pellet, again following our consensus conference, meaning so we combine a bone graft with an autologous, so with an autologous graft to cover the socket. So removal of the connective tissue graft, as you see it here. So I removed the connective tissue graft here on the mesial side of the Pellet, and of course then suture everything up. And then I did my ridge preservation or socket preservation, coming back to my clinical situation. Here you see that the blunt tunneling on the buccal side. Now I insert an elevator in order to have enough room for my membrane. In dehiscent cases, I always place a membrane on the buccal side in order. Here you see nicely the palatal ridge, but I always place a membrane on the buccal side in order to be sure that my bone graft is completely contained. So I use a Fibro-Gide in this context, and I move this on the buccal side over the defect. Now BioOs, this is just BioOs, not BioOs collagen, and I use the classical BioOs in this context. Fill this into the extraction socket, as you see it here, and now because I placed the Fibro-Gide on a buccal side, I can be sure that my graft is contained. Of course, you could open a flap a little more wider, but then you have the risk of deteriorating the papillas, and of course, in this case, I didn't want to do that. Now I tucked the membrane into the palatal side, and then I used my connective tissue graft in order to more or less, to secure the whole aspect, and also at the same time increase soft tissue thickness. Just look at the gingival thickness now, it's quite thin. So just imagine what can happen over the time if you have these kind of thin soft tissues, in particular when your implant is in place in this context. Now I use an anchorage suture, a sling suture, in order to move this connective tissue graft into the buccal envelope, and I do the same thing on the palate and tuck this connective tissue graft underneath the palatal aspect as you see it here, and now I have this saddle shape connective tissue graft in this area. Here's the clinical situation. You see, of course, you have a lot of swelling in there, but nice integration of this connective tissue graft. And 5 months down the road, you see you have a nice rich architecture. You have a thick soft tissue. And of course, if you elevate the flap, you have a nice regeneration of the ridge. Just remember how much loss there was, but of course, the ridge preservation procedure was able to attain an adequate amount of bone. And of course, it was not a big issue to place the implant here in the right position, in the right prosthetic position in this context. Now, I think these were the first two aspects of soft tissue thickness and soft tissue height. And for me, it's clear, if I have a situation where everything is perfect, I would try to keep it. And in these contexts, the hard tissue is even more important for me, because I know with an adequate amount of hard tissue, I also support my soft tissues. And in this context, of course, a non-resorbable or slowly resorbable replacement material like BioOs is ideal. In situation where I do ridge preservation, I also think that the combination of a xenograft plus a collagen membrane is ideal. And in situation where you want to improve the soft tissue height from the outset or from the onset, you can use autogenous soft tissue grafts. Now, let's move a little bit away from the soft tissue, from the autogenous soft tissue grafts, because of course it's quite visible that these are, well, quite invasive surgeries. The question is, how can we use soft tissue matrices? Well, soft tissue matrices are of course a good idea, especially in the field of extraction socket and in the preparatory phase around dental implants. So what we have done a couple of studies where we did ridge preservation and socket preservation, and we always used an autologous soft tissue to close the socket. So if we look into a case, then you clearly see this kind of procedure. So filling the extraction socket with BioOs, using a punch graft from the pellet in order to seal the socket orifice, and then I have a nice clinical situation at the time of re-entry, and I'm able to place my implant into the alveolar housing. On the other side, we saw some disadvantages with the autogenous soft tissue grafting. And of course, one disadvantage is, of course, the morbidity. But the second disadvantage is something more aesthetically or something more cosmetic. And we always saw scars. So if I show you the final reconstruction of the case I just presented to you, it looks like this. And you maybe say, well, the situation doesn't look too bad from a soft tissue perspective. However, we see scars. We see scars, we see situation where the quality of the soft tissue is not perfect. And this is because of autologous soft tissue graftings. We did a study and published this study 2 years ago and compared the use of autogenous grafts in the field of extraction sockets and the use of mucograft seals or collagen matrix to seal the socket orifice. We looked into scar score, follow-up treatments and costs. And dear colleagues, it was quite clear. If you use a product with collagen, you don't see any scars, because you see an increase in soft tissue healing because of the collagen, and you have, of course, much less follow-up treatments, and the costs in these cases are definitely lower than if you would use autogenous grafts. So here's the statistics behind this. You clearly see that in these situations where you use collagen matrices to seal the orifice of the socket, you have less scarring, probably because of the collagen, which is improving the wound healing, and you have less costs in these cases because these materials, this situation don't need to be corrected so many times than in this situation where you have used autogenous grafts. Now, what does that mean for us? Well, this means for us in many cases we use xenografts. So we use mucograft seal to seal the orifice of a socket, and then we know we don't have any scars, we don't see any scar tissue on the buccal side. The soft tissue blends in nicely in this context, and this is the way we go in many cases. So here's a clinical situation where we take out a tooth, we place bio-os collagen in this context into the socket, and we use mucograft seal to seal the orifice of the socket. So we use this as a replacement material for our autogenous grafts, and we correct the soft tissue with this approach. Now, going back to the clinical situation, here you see the situation after 8 weeks. You see nice soft tissue healing, you see the thickness of the soft tissue which is maintained, and at the same time you also see that there's not a lot of volume shrinkage in this case, which is probably due to the grafting of the extraction socket with bio-os and also the mucograft seal. In cases where I use resin bonded bridges, I immediately start to sculpture my pontic. So in this case, I started with an Essex retainer and just added some pressure on the subgingival areas to push the situation to the buccal side, to push the situation to the palatal side, also to push it to the interproximal side. And I do this in many appointments or in different appointments in order to achieve a nice pontic result in this case. Here's the clinical situation after 2 weeks. So you see the sculpturing of the tissue with this subgingival appliance, some pressure on the buccal side, some pressure on the interproximal side, and by this you really improve the pontic area. Then you can final reconstruct it, and this is the final restoration. In this context is a resin bonded bridge on the canine just with one wing, and you see how nicely the soft tissue blends in, and also you see how nicely the soft tissue is preserved in this context, and this is due to the grafting of the extraction socket with bio-os, but also due to the nice blending of the soft tissue healing of mucograft seal. Here's the situation 3 years down the road. You see literally no change over time, so there seems to be stability in these cases, and we know this then if you graft with bio-os that there is a stability in these sockets. Now, coming to the last aspect, so I think we saw that improving soft tissue is very important to support the underlying bone level, and by this to prevent complications like bone loss. The best thing to do is, if you have everything, stabilize everything. If you don't have anything, improve the soft tissues already at the time of tooth extraction. Consider xenografts, especially the soft tissue matrices at the time of tooth extraction, because they blend in much better than the autografts. Now, the question is, what about augmentation of soft tissue volume already at the time of implant placement? Of course, you can use connective tissue grafts, no doubt. But the question is a little bit more, how can we improve soft tissue already at the time of implant placement with a collagen matrix? Just imagine you have a situation where you already flapped the clinical situation and you see, well, the soft tissue are fragile, are very thin. So you want to do something for second stage surgery in order to get more soft tissue thickness and height. Well, Of course, Fibro-Gide seems to be the way to go in this context, because this is a material which at the same time has a very nice soft tissue integration because of the collagen, but also because of the chemical cross-linking. It improves the volume stability and gives you some more volume in your soft tissue, so increases soft tissue thickness and soft tissue height. And this is perfect for the maintenance of your bone levels around dental implants. So there's data from Dani Toma showing us clearly that there doesn't seem to be a big difference between connective tissue graft and Fibro-Gide, especially in the context of soft tissue thickness augmentation. So both of these materials you can use in order to increase soft tissue height and also soft tissue thickness. I would like to give you two clinical indications which work quite well in my hands with Fibro-Gide in order to improve soft tissue thickness and height. And as you see it, it's most of the time in the functional zone and in posterior zone. This is not because of aesthetics. I'm doing this clearly to increase soft tissue height in order to prevent marginal bone loss around my dental implants, and by this to prevent complications. So one aspect would be soft tissue preparation at the time of implant placement. So this would be the scenario which I told you in the beginning. You have a clinical situation and the soft tissues are thin. So maybe already at the time of implant placement, you increase soft tissue. And of course, there could be a situation where you see at the time of second stage, like as you see it in the upper right pictures, the soft tissues are fragile, they are too thin for good long-term maintenance. Then you can also use Fibro-Gide in this time. So here's a clinical situation at the time of implant placement, a situation after bone augmentation. So I'm ready to place my implants, but as I see, there is a very, very small amount of soft tissue height and thickness. So look at the flaps. It's 1.5 millimeter thick, and I have a clinical situation where I really want to have a nice and thick soft tissue apparatus in this context. I have enough bone, so what I do is I use some soft tissue management to prepare myself for the second stage surgery, where I want to play with the increased soft tissue. So here you see the Fibro-Gide, which is placed into this buccal housing. So I place the Fibro-Gide underneath the flap in order to increase soft tissue thickness at that time. It's quite important to do a meticulous suturing. So I use a 5-0 Gore-Tex suture in order to adapt the wound margins. And then I use just single knots in order to close everything, or double cross sutures to get an intimate contact over this grafted situation. Now, of course, we know that this material heals quite well, and this is already the situation 4 months down the road after healing of the implants. And you already see from a clinical perspective, there seems to be a difference. So the soft tissue is thicker, the soft tissue look more pronounced. And of course, this is what you can use at the time of second stage. So what I'm now doing, I use this increased soft tissue thickness in order to really put enough soft tissue around my healing abutments. So what I do is I use a palatal or a buccal reposition flap. Again, it's also very important to have enough keratinized tissue or attached tissue on the buccal side of your implants. But of course, tissue thickness is also important. And in this case, you see that tissue thickness was not there in the beginning, and then I used collagen matrices to improve soft tissue thickness. Now, as you see it here, just look at the edge of the flap. I think a nice soft tissue thickness, which has been achieved by soft tissue thickening. And now, of course, I can use this soft tissue and reposition this on the buccal side, and at the same time to the second stage procedure. So what I do is I increase the amount of keratinized mucosa, but I also increase the amount of soft tissue height. Now place the healing abutments. I think this is quite clear. And then I use some suturing in order to close everything. In some cases, I like to rotate sometimes a little bit from the palatal tissue in order to close the interproximal spaces. This is not completely necessary, but in this context, I had the feeling that especially between the two implants in the position of the bicuspid, there's an inadequate amount of soft tissue in between the implants. So I use this small Palachi flap in order also to reconstruct the interproximal soft tissue height. Then we use sling sutures or also mattress sutures in order to increase the soft tissue or put the soft tissue in a more coronal position. See, we suture this around the healing abutments, and we also use the healing abutment to judge how much soft tissue will we have, or with how much soft tissue will we end up in this case. So here's the situation fixed on the distal aspect, and then I use this crossed mattress suture really to push up the tissue on the buccal side in order to improve the soft tissue height and thickness. And again, last suture on the mesial aspect is also fixating the mesial flap and also attaching this small interproximal flap here to the buccal flap. Now, again, a clinical detail, and I always like this picture, very nice. So I think this is a good result which has been obtained by augmentation with Fibro-Gide. You see a nice and thick amount of tissue which we can reposition, of course, on the buccal side as you see it here, and of course with this achieve an adequate amount of soft tissue thickness. Now, this is the clinical situation at the time of final impression, and you see the 4mm healing abutments. Most of them are flush with the gingiva, so this seems to be an adequate amount of soft tissue height which has been established here. And final reconstruction, full ceramic crowns splintered together on these 3 implants here. Now, this was a clinical situation at the time of implant placement. The question is, how can I use these xenogenic matrices at the time of second stage to improve soft tissue height? Well, here's a clinical situation with, of course, an inadequate amount of soft tissue height and thickness at the time of second stage. And obviously we have to do something here because we have an invagination, we have a fragile and small amount of keratinized tissue. So what we do is we prepare the flap, we do a small tunneling or a small flap procedure, a small partial thick preparation on the buccal side. We use a Fibro-Gide on the buccal side, but at the same time use sutures to push this up. You see again, we use the healing abutment. It's a 4mm healing abutment to judge the amount of soft tissue height in this context. And if you look at the clinical situation at the insertion of the final reconstruction, I think with a xenograft, this is really a nice result which has been established here. And if we compare the starting point at the time or just right before second stage and the clinical situation at the time of final impression, then I think we have to say that it is a nice result which has been obtained with this xenogenic soft tissue matrix in this context. Now, one more case in order to summarize this. Here's also a clinical situation at the time of second stage, and you see this small invagination on the buccal side, so it's an anterior case. So what we do is we use the Fibro-Gide, as you see it here, and insert it into this buccal tunnel. You see and how much volume it creates already just by packing the Fibro-Gide into the buccal volume. And then in this case, I already used a provisional at that time to sculpture the soft tissue, but just look at the bulk of soft tissue which has been established by this xenogenic matrix in this context. And if we look at the clinical situation, then this is the clinical situation at the time of final impression in this case. And I think it's a nice soft tissue volume and also a good soft tissue height, which we achieved with a collagen matrix in this context. Again, the point at the time of second stage and the situation at the final restoration. And this is just managed or achieved by a xenogenic collagen matrix. And I think this is a quite acceptable and good result in this context. And just to document the long-term stability of these materials, you see also this seems to be good. It's 2 years following soft tissue augmentation with Fibro-Gide. You see there's literally no change. There's no shrinkage over time in this case. So, dear colleagues, I would like to summarize and give you my ideas of, well, my thinking about soft tissue management around dental implants. I think we saw that soft tissue is important from an aesthetic standpoint, no doubt. We need soft tissue thickness to use our prosthetic components. Just remember this case with the pontics where I created a pontic. Without soft tissue, you cannot do that. However, on the other side, we also saw over the last years that soft tissue is also there to prevent our complications or to prevent bone loss around our implants. I think we cannot say so far that soft tissue augmentation prevents peri-implantitis. I don't think we can say that, but at least we see that it seems to stabilize the marginal bone levels. So what aspects do I think are important in my daily clinical work when it comes to soft tissue correction? For me, the best soft tissue is the one I have. If I have a perfect soft tissue thickness and height, well, I use a bone graft. I use bio-os to support the bone and by this support also the soft tissue. If I have a clinical situation where I want to take out a tooth and do ridge preservation, if I have a very thin clinical situation, I'm considering to use autografts in combination with ridge preservation with bio-os and Bio-Gide. However, we sometimes see scars as a disadvantage of grafting with autogenous grafts, like scars on the buccal side. An alternative definitely for us is mucograft seal, where we have a nice blended healing in these cases because of the natural collagen we have here, so we don't see any scars on the buccal side, and we have a nice volume maintenance, of course, by the grafting of the socket and at the same time of the closure of the orifice of the socket. Well, at the end, the question is, how can volume stable collagen matrices help us? Well, like Fibro-Gide, I think for me, the best indication is the preparation of the soft tissue. So in a closed environment, I'm using these xenogenic matrices in order to improve the soft tissue already at the time of implant placement and then to use the tissue at the time of second stage. You can also use it at the time of second stage to improve soft tissue in the functional zone or also in the aesthetic zone. And this seems to work quite well, especially in small gaps where the situation or where the teeth, the adjacent teeth, they also support the clinical situation. With this, I would like to thank you for your kind attention. I would like to thank Geistlich for making this possible, this webinar tour. And I'm very happy to discuss with you now in the next minutes about soft tissue aspects, about controversial standpoints, or maybe clinical aspects of my work. Thank you very much.